Okay, so we have a 3-year-old boy presenting with his mother with puffy face, and the doctor gives him antihistamine. However, this did not work, and the boy is asthmatic but generally well, takes no other regular medications other than the ones for his asthma. On examination, he has puffy eyes and pitting edema. Heart rate is 109, blood pressure is 103/72, cap refill is 22 seconds. There's no abdominal distension or organomegaly. The scrotum appears edematous. Respiratory rate is 28, and there are no other respiratory signs. On the right, you can see his blood results, and the only abnormality that I can see is a bit of white blood cells being raised, and then we've got the albumin, which is really low, and we've got his platelets here, which is a bit raised, and then we have his urine dipstick, and which shows blood +1 and protein +4, which is a lot. So I'll give you 5 seconds just to pause the video and take a look at the whole scenario and come up with your diagnosis. Okay, so well done to those who guessed it correctly. Yep, so it is nephrotic syndrome, and let's work this out together. So A says IgA nephropathy. This is in the setting of upper respiratory tract infection, but then the boy did not have any upper respiratory tract infection, so we can easily rule that out. Heart failure, we can see that he's kind of hemodynamically stable, especially that his cap refill is 2 seconds, so we can easily rule that one out as well. We have respiratory distress syndrome. This is more common in those who are born prematurely, and there's nothing in the history indicating that this boy was born prematurely. Nephrotic syndrome. Now this is a bit tricky because actually 20% of those presenting with nephrotic syndrome do have a bit of nephrotic syndrome as well. But then considering the whole thing, the blood results and the clinical signs and symptoms, nephrotic syndrome best matches the picture. So let's talk about nephrotic syndrome a bit more. So it is a triad of edema, heavy proteinuria, and hypoalbuminemia. More common in those who are between the age of 2 and 5, and 90% is due to minimal change disease, or MCD. Complications, hypercoagulability. So this is when obviously there's a protein loss in the urine, and what the liver does is by compensating for those proteins that are lost in the urine by making more clotting factors. You're also more prone to get infection, again due to those immune complexes that are lost in our urine. Hypovolemia, again due to less albumin being in the blood, which means that fluid can easily escape into the interstitial environment. Now, how do we diagnose it? It's mostly based on clinical signs and symptoms. There's obviously low albumin and proteinuria, which is more than 3.5 grams per day. You have low blood pressure. Again, this is due to hypovolemia. And in adults, in order to make a diagnosis of nephrotic syndrome, you do actually have to do kidney biopsy to make a diagnosis. So how do we manage it? You start off with high-dose prednisolone. And if the albumin levels are severely low, then you start with albumin infusion. And now, interestingly, for the high dose albumin, adults don't respond to high dose prednisolone, as well as the young patients. Then you advise them to take to lower their salt intake, and you give diuretics for edema, and you give them prophylactic antibiotics such as penicillin. Why this is so? Because obviously, again, we did say that immune complexes are lost in the urine, so the body is less able to fight infection. So you give them prophylactic antibiotics, especially that nephrotic syndrome happens again and again in 70% of patients. So it is best to give antibiotics. Okay, so hope that was helpful.